The OSCE was my least favourite part of medical school. It's a horrendously high pressure exam, and it's usually the thing that's sitting between you and becoming a doctor. So it's natural to be nervous, but hopefully this video will settle your nerves. I'm going to go through my full cheat sheet, which is available in the link in the description below. I'm going to cover some of my top tips, how to approach the history, the examination, the investigations and presenting your management, and also some pre-exam prep stuff that will help as well. So my top tips with this: first of all, remember your meta structure, that you are always doing a history, examination, differential diagnosis, investigations, and management. And in the high pressure situation, it's easy to forget that that's what everything comes down to. So it's okay to just take a step back and be like, okay, what's my framework? And you can signpost this. You can convey this to the examiner. It's totally okay. That signposting in itself is actually a demonstration of competence, because it shows that you're using a system. So even if it feels weird, like you're narrating yourself as the main character in a story or something, you can be like, right, I've completed my history, now I'm going to move on to the examination. 90% of students will pass and they'll get enough marks just from history and examination alone. So if you stick to the structure and demonstrate that you're systematic and that you're safe, that's pretty much all you need. You don't need to be encyclopedic. You're just being tested on, is this person safe to have as a junior doctor in the hospital? The other thing is, don't be weird. Again, it's about examining good quality basics, but also not setting those little alarm bells up on the examiner. You want them to fall asleep. And something that I see people do so much is they put on this like weird persona, like this kind of OSCE persona, and it's much better for you if you turn up and you're relaxed and you're natural, you're conversational, rather than like awkwardly trying to tick boxes and try and be someone that you're not, because that's immediately going to prick up the ears of the examiner and they'll be like, gonna have to pay close attention to this guy because they're a bit of a psychopath. So if you try and box tick, it's going to be written all over your face. As I say, put the examiner to sleep. Just, if in doubt, be empathetic. You can like touch the patient, but not in a weird way. Make good eye contact. Just be vanilla. And you can record yourself as well to spot any kind of weird tics that you might do when you're nervous. Also, own the consultation. So this is where you set your agenda, you explain what it is that you need to do with the patient, and that you're collaborating with them. Keep track of timing. So you might want to have a belt watch. Just don't constantly look at it because it obviously looks quite rude if you do that. When it comes to questioning, answer the question that you've been asked. Don't do what I did and try and answer a different question that you do know the answer to, because you'll just get slapped right back. So listen to what they've asked and clarify if you're not sure. And if you're not sure, don't bullshit, because that is worse than not knowing the answer. It's much better to be like, do you know what? I don't know, but here's how I'd find out. Here's where I'd look. That's safe. You can't really argue with someone that does that. Also, ignore the frosty face. You might have seen the, what's it called? The plain face experiment, where a mother and baby are brought into a room and the mother's instructed to just look at the baby with a blank face, and the baby immediately starts like cracking and crying and trying to get mum's attention, and it's really distressing. And the examiners are instructed to not give anything away with their face, and naturally as humans we want to try and build rapport, and when that's not happening we get more nervous. So just remember, that's what they've been instructed to do. Don't let it rattle you. Cheat sheet, oh yeah, so that's in the description as I mentioned. Now, before entering the exam, this is the grid that I like to draw on the bit of paper. You'll usually have a few minutes to just sketch out on a blank bit of paper, and this just helps me to stick to a system. So for me, I've got this laid out in this particular format. If you have a format yourself that you prefer, then go for that. I'm going to go through the specifics of mine, but as I say, adapt it to what you do. Also, breathe. It's very easy to sit down and you're like, oh, psoriatic arthritis with alpha trypsin, whatever, and you're like, I don't know what that is. And then you just sit down and think, okay, what do you think they want me to know at this level? If you goofed on the previous station and you're still reeling from that, don't let it ruin your next one and your next one. It's a fresh slate. That the examiner in that room hasn't seen you before, so they don't know that you made an absolute arse of yourself in the previous one. So, history. I like to think of this as a converging funnel where you start general and then you get narrower and more specific. So, keep the patient on topic. They should be trained to not be too rambly, but if they are, you can be like, okay, that's interesting, but let's come back to that. And you can cut them off as well. Be like, Margaret, that's enough now, Margaret. Let's just come back to this. Or, that's interesting now. Because you said that, I'd like to ask you about this. And you can then do quite a tactful handbrake turn without looking like you're being rude and steamrolling the patient. I like to use COD-P as my approach for presenting complaints. So what's the course, the onset, the duration, and previous episodes of the presenting complaint. Now, my university were really big on ICE, something they really hammered, but that's ideas, concerns, and expectations. You've got to come up with some natural way to ask those questions so that it doesn't come across as too robotic. I quite like these ones. So these are the ones I've arrived on, particularly with expectations. Like, you've obviously given this some thought. What were you thinking would be the best way of us tackling this together? It shows that you're collaborating with the patient. Impact is one that I add to the end of ICE as well. So if it's a chronic condition particularly, you can be like, and how has this affected your life? And then maybe dig into a little bit of that. But remember, that could be a can of worms in terms of time. So keep an eye on the time and don't let that dominate the consult unless that's part of the brief that you've been given. Red flags. So I like to use WAFTs. This is weight loss, appetite, fever, tiredness, and sweats. So these are the red flags for cancer. Plus, if there's any major risk factors that you're picking up from the brief, if it's a serotic picture, for example, maybe you want to ask about alcohol history, or if it's something that could be STI related, you maybe go into a bit of a sexual history or whatever it is. Oh, it's getting dark. I'm just going to turn on the light. Oh, that's a bit bright, isn't it? But never mind. So a great easy catch-all for this is anything else. Just leaves it open in case you've missed the elephant in the room, and the patient can do that. You know, they're not trying to catch you out and hide things from you. Remember as well that there's only one point available for each of the components of the history and the examination. So don't go too deep into stuff. You know, it's basically student has asked about family history. Unless that's a critical part of the station, just move on. With the past medical history, I would break it up into, do you have any health problems? Have you had any surgeries? And is there anything that you see a doctor for? Annoyingly, I'm sure you've had this before where you'll ask someone, do you have any medical problems? No, doctor, I'm absolutely fine. I've got no, and then you're like, oh, but what about your rheumatoid arthritis and your alcoholic liver disease? And and your diabetes. Oh yeah, well, I'll take the thing for that. And I do. Oh, and I see here that you've had 5 heart attacks. And oh, well, yeah. So sometimes the way that you ask the question can also impact what answer someone gives you. So that's why you can kind of sweep a little bit with those 3 questions. With social history, go through exercise tolerance, home situation, any adaptations to their home, do they have carers, what's their mood been like, have they got support at home, follow up on anything that they might mention that could be related to the diagnosis, and just have a bit of empathy with this as well. You know, if someone's like, oh yeah, I've had this chronic pain, I've not been able to get out of the house, and then my mum died, and you go, okay, and do you have any allergies? Like, just don't be a weirdo. Drugs, so again, ask about over-the-counter drugs, compliance with the things they're already taking, and allergies to both food and drugs. So there's a few pointers for history. It's not exhaustive, obviously, but make sure you go through your framework and dig into what's necessary. Then we've got examination. So again, it's okay to signpost and be like, I am now going to examine your heart. I'm going to do this, this, and this, and be systematic. You know, every type of examination has its own cluster of things that you would do. And if it's, I don't know, like an elbow exam and you've never done one before, just go back to your basics. Like, okay, well, generally, how would I examine a joint? I would look, feel, and move. And then just have a crack at the elbow. You might look a bit weird, but it's okay. Don't auscultate the elbow or the testicle or whatever. But so apply the right framework to the right thing. So yeah, obviously you've got inspect, palpate, percuss, auscultate, or for neurological style exams, inspect, tone, power, reflexes, coordination, sensation, and special tests. When you're observing in the exam, that helps you to buy some headspace. It allows you to just stop, take stock, look around, see if there's inhalers on the side of the bed, if there's anything that gives away what the differentials could be. And don't be afraid to expose the patient. You're there to examine them. So you could fail a station if you don't adequately expose a patient's chest when you're trying to do a chest exam. So don't be shy, just make sure it's kind of appropriate to what you're doing. And if they've got obvious scars, you're okay to ask about them. That's not cheating. The other thing is, if it's a finals exam where you're expected to be a bit more specific, you're not just trawling like you would earlier in medical school, is ask the examiner, like, okay, this patient doesn't have clear signs of ascites. Would you still like me to demonstrate how I would examine for ascites? And usually they'll be like, no, it's okay, because they get that you know what you're doing there. Whereas if you're examining someone with a flat belly for ascites, it just looks a bit odd as well. So, summarizing. This is actually really hard as a skill, and I would recommend practicing it when you're doing your reps at home. I really like ASPOP. So that's age, sex, social, presenting complaint, onset, past history. I met this 41-year-old man who works in a construction site. He's presented with 3-day left flank pain. It came on when he was bending over at work. He's got a history of type 2 diabetes and melanoma. Sorted. So it's just a very nice way to construct a brief summary of a patient. When you're talking about differentials, this is a really useful way to summarize. So you can say, based on 1, 2, and 3 in the history, my top diagnosis is this, secondary to this. I would want to rule out this, and other things it could be might be this. So you've got A, the primary differential. My preferred diagnosis is this. Things I want to rule out, which might be serious diagnoses or similar related ones. Other things that it could be this, and maybe sort those out by system. This picture may be caused by this, and then that shows that you really are thinking quite widely with this. Like that's bound to get a good response from the examiner. If you can, and if you fancy a bit of flair, and you're thinking of some kind of scoring systems related to the differentials, this is the time to mention them. So with your examination findings, don't just go through and say like there were no additional sounds on the chest and the mouth was clear and no additional, like talk about positive findings first. You know, the left upper quadrant was tender and there was a big old rash on the whatever. Like those are the things which are important. Don't kind of mention them as like a needle in the haystack amidst a bunch of negative signs. So think, I'm reporting this to the consultant, they're busy, they're rushing around, what do they need to know right now? You can also use this kind of framework that the patient was comfortable at rest, they're not acutely unwell, etc. And then talk about, these are the further tests that I would do, like after you've highlighted the positive signs. If you're not sure what you're looking at, it's okay to just describe what you're seeing in plain English. And you don't have to use kind of medico-babble for it. Just say, look, the signs that I'm looking at are not consistent with my knowledge of rheumatoid arthritis or osteoarthritis, but there is some erythema on the hands and some swelling of the fingers. And if you forgot to ask something while you're examining or whatever, like you're not like, oh, well, I've done the history part now, so I can't go back. Just say, oh, I would also go back and mention this. Just don't do that constantly, because otherwise you'll look quite chaotic. When it comes to investigations, have the differentials that you've mentioned before in front of you, and then think in terms of what am I ruling in and what am I ruling out. You might want baseline tests, but don't just say, I would do Usene's, LFTs, but chest x-ray for baseline. You want to say baseline for what? Like, what are you potentially going to do to the patient that might derange the baseline, and therefore it would have been useful to have that baseline. Maybe if they need surgery, you might want a group and save and a clotting screen. So generally when you're doing investigations, something that you might see people do in the kind of earlier years of med school is just reel off a whole bunch of them and hope that they won't get pulled up on it. But then as soon as the examiner's like, interesting, a globulin, why? And you go, I don't know. You've got to have some justification for it, and then you won't sound like a gimp. Next things are, so have the differentials in front of you when you're planning the investigations. Other things that can be part of investigations could be a collateral history and maybe enhanced observations, things like a blood glucose or a lying standing blood pressure, an ECG or a urine dipstick. And you want to start in the order of conventional investigations and leave the weird ones for last. Don't go straight to some like fancy genetic screening that's only available in Tokyo. Always give a reason for each investigation. Talk about why you're ruling things in and out. So we've mentioned that. Don't assume that the examiner can read your mind. It's okay to give a little hat tip to each thing as you're going through. Just remember common things first rather than weird and wonderful things. Then you've got bedside blood and imaging. So the standard, I usually go in that order with that framework. So bedside, be explicit about which observations you might want and why. For example, you might want to include things like peak flow, stool culture, as I said, lying standing blood pressure, maybe a pregnancy test in a woman. Bloods, so list through the relevant ones there. Maybe have a grid that you can look at home to try and be aware of what bloods kind of jump out at you, because it's quite easy to go blank if you haven't looked through the range of options available to you. And then for imaging, again, go for the ones that are acutely available and easily available, and then things like MRI and fancy forms of imaging can be done further down the line. Okay, almost there. On to management. So there usually will be a generic question of, tell me how you would manage this patient, or even what are 2 risk factors for the presenting complaint this patient has. So you want to start with explaining to the patient what you found. That buys you some time, but it also shows that you're patient-centered. Then you can talk about the aims of the management. So it might be symptom control, or it might be disease management, and they have different approaches to them as well. You can also approach this as acute, conservative, medical, and surgical. So acute is kind of resuscitation type stuff. Might want to talk about your sepsis 6 and that kind of thing. Remember that the role of the F1 is basically to stabilize the patient and be safe. And then beyond that, as I say, you've got reducing symptoms, preventing complications, and minimizing side effects. Patient education is still part of management, and again, it's an easy one because it's just possible for basically any presenting complaint. So we've covered acute management. Let's go on to conservative. So you talk about the multidisciplinary team, and it's worth, again, having a grid of them at home and knowing what each of these roles do. And patient education, that's still part of conservative. Consider in a geriatric patient, you've got all the frailty syndromes, and that's where MDT really comes into place. You might want to get some input or some advice from a senior or from a specialist. And then maybe just as a final scraping the barrel, have a framework that's systems-based, because there might be conservative management that's standard for the respiratory team or the endocrine team or whatever. Next, we've got medical stuff, so disease modifying and symptom control. Is there anything that they're currently taking that might be worsening what they're doing? So are there any medications to stop? Anti-inflammatories or analgesia or something like that could be causing them more problems before adding in more drugs. Then surgically, the standard surgical stuff, especially at a F1, F2 level, would be catheter and a VTE assessment, and test the urine, maybe do a group and save, make sure you got the TINs, TEDs, regular meds. And you might want the patient to be nil by mouth if they're going to be considered for surgery. You might want to place an NG tube. Then for ongoing management, you want to be patient-centered. You want to focus on the fact that you've explained to the patient, you want to discuss with them and basically form a management plan in partnership with the patient with informed consent throughout that. You don't want to be like, I'm just going to do this unilaterally to the patient and don't care what they think. Then you've got the biopsychosocial stuff. It's just a final Salt Bay icing on the cake. So talk about discharge planning and starting early, exploring the home situation, carers, social workers, maybe writing a letter to their GP, lifestyle stuff if it's appropriate, counselling for that, maybe not in an acute situation. And then if you have time, any considerations for follow-up as well. So that's it for the management. So we've covered the top tips for the exam, the prep and before entering to create that little framework there, history, examination, summarising, management, and if you want the notes as well as the cheat sheet for the SJT, the PSA and the WRISKE, they're all available in the bundle in the description below. Hope you enjoyed the video. Best of luck with your OSCE. Speak soon.